Good morning, and thank you for the opportunity to speak to this distinguished group of people this morning. What I want to do in the next 15 minutes is spend some time talking about the role of health and healthcare, the role of innovation in helping to transform health and healthcare, and in many ways set the stage for the upcoming plenary session. So I'll first start with a very brief overview of the context of why we need innovation. This should be no surprise to this audience, given all of the distinguished speakers we've already had that have addressed this. I then want to talk to you about some of the lessons we've learned from working and studying innovators, and this idea of developing global knowledge networks as one of the conduits to moving the field forward. And finally, as an example of the role of a university and academic health system in the space of innovation, I want to tell you a bit about what we're doing back home in the US at Duke. So I think others, including Dr. Srinath Reddy, have done a very nice job of outlining the dire statistics of why there's a need for innovation. To me, this one graphic tells you all you need to know. Not only do we have needs all around the world, but there's also incredible inequity. If you happen to be born in parts of sub-Saharan Africa today, you can expect to live half as long as someone who's born in Western Europe or the US. In addition to these health disparities, we know that systems aren't generating value. So if we take a look at this chart, on the x-axis we have the input, so how much our government spending is on healthcare as a percent of GDP, and on the y-axis you have one of the key outputs, which is the life expectancy at birth. And what we see are clear outliers like the US, where we're spending now 18% of our GDP on healthcare and achieving results that are far from optimal. And I think every government struggles, as we've heard over the last 2 days also, with how to actually achieve the most value out of the spending and the human resources that are developed into healthcare. We know that the world is also changing rapidly. So we've heard about non-communicable diseases, now chronic conditions and injuries. The demographics are shifting. Much of the world is aging rapidly. There's a lack of high-quality infrastructure to support acute care services as well as primary and community-based care. And we've heard over many sessions about the lack of human capital as a driver for health and healthcare. And this, the flip side of these challenges is that these are opportunities, and these are opportunities for entrepreneurs, innovators that are developing transformative innovations that really cut to the core of what we need in health, which are to address the three issues of access, quality, and cost or affordability. And I want to move to a very optimistic message, which is that we know that things are already happening. We know that there are already innovators that are developing solutions that could be transformative. One of these is Medical Home in Mexico, and we're going to hear from the founder in just a few minutes, where they've developed a call center-based model to provide 24/7 access to doctors and nurses and piggybank that off to a telecom service so that they're able to dramatically increase access in a cost-effective manner. One of these is in Rwanda, where One Family Health has developed a public-private partnership with the government, with GSK and with EcoBank, to develop a business franchise model of nurse-owned and operated clinics that are providing access to medical care as well as life-saving medications for many people in sub-Saharan Africa that wouldn't otherwise have it. And you'll also have a chance in the next plenary session to hear from the co-founder of One Family Health. This is solutions coming up right here in India, and I think being in India is a fantastic place to have this conversation because there's such a large cluster of innovation. This is in the Narayana Health system, and I think we'll have the pleasure of hearing from Dr. David Shetty later today. And they've developed over many years this model of what we'd call a production specialization or focused factory, where they're able to do incredible volumes of high-quality procedures for very cost-effective mechanisms. And as we look at these, what we see is a clustering of the types of innovations into different business models. Like One Family Health, there are ways to use business franchising principles to look at social franchising as a concept to scale innovation. Like Medical Home, there's the opportunity to leverage technology to develop networks and expand access. Like Narayana Health, there are opportunities to look at production specialization as a business model to be able to expand access in a cost-effective way. And there are other innovators that are trying to put all of this together to actually develop an integrated model of care by putting the pieces together. So there's incredible work that's already ongoing. And to be able to study this further and also to support the work further, 3 years ago, we co-founded as Duke University, along with McKinsey and Company and the World Economic Forum, a new nonprofit that's called the IPIHD, the International Partnership for Innovative Healthcare Delivery. In the next plenary, you get to hear from two of the co-founders, Dr. Victor Zhao, who serves as the chair of IPIHD and represents Duke, as well as Mr. Tom Kabasi representing McKinsey. But the idea here was really built on the construct that if we could curate the world's leading network of innovators and supporters, what we could then do was deepen our understanding not just of the innovations but of the ecosystem. So what is it about India that's actually facilitating all these innovations from happening, and what can we learn about what helps and what hinders the growth and scale of innovation? And if we could take those learnings and codify them, we could not only reflect that back to helping innovators to scale their models, but also to generate more knowledge and insights that could be used more broadly all around the world. And through that, we enhance the engagement and continue to create the network. So what we hope is building a virtuous cycle through this work. And you'll hear much more from Dr. Zhao about the success that we've had in the first 3 years and some of the impact we've been able to have. What I want to do, though, is shift to this idea of a global knowledge network, that there's no single place, there's no single organization that can do this alone. Each of us has a role in developing specific insights, in helping to teach each other. This chart here shows you from IPIHD, we went back and just over the last year actually outlined and documented all of the specific bilateral connections that have been able to be made through our network. It looks very much like a flight map of the world, but I think what this points out, though, is that this really is a global challenge to meet the health and healthcare needs, and it has to be global solutions that we move toward. And some of the ways that we can start leveraging this type of global knowledge network is really to be able to scale and replicate. And I want to give you two examples of that, both of them that leverage innovations happening in India. One is an example of a South-South innovation, and the other is what we'd call a reverse innovation model of a South-North. And then more broadly, we hope to take these learnings to generalize and disseminate principles. So many of you in this room are aware of Arvind Eye Care, based in South India, that over many decades has developed a model that is leading to very high quality and very low cost solutions in eye care, where they're now doing cataract surgery for $20 to $40 US as compared to $2,000 in a US context. Incredible work that all of us in the world could learn from. I want to tell you the story of an organization called Sala Uno Salud that's based in Mexico and was co-founded by investment bankers. And what they were able to do is actually understand the model at Arvind, actually embed themselves in their team for many months to actually take the business principles out, and found an organization, Sala Uno, in Mexico that now has done thousands of cataract surgeries at 1/3 of the market price. And so this is at least one small proof point that these are principles that can be generalized and replication is possible. A second one comes from, again, going back to Narayana Health, is the idea of why we can't do this in the US. Right? And this is a paper that was just published in the Harvard Business Review, where they estimated, based on the current model, that in the India context, they can do a coronary bypass surgery for about $3,000 US. And you can see on the bottom right of the screen, the model in the US is that this costs anywhere from 75 to hundreds of thousands of dollars in the US. So this would be an incredible innovation. And we always get caught in this idea that the human capital piece is the part that can't be changed, that you have to have highly compensated physicians and nurses and other personnel that are providing care in a US context. And what the authors here have shown is that even if you modify the cost and put the labor costs into a US context, you could still do a coronary bypass surgery in the US for under $15,000, which would be a tremendous saving. So this is another proof point that not only is it possible, but we need these types of transformative innovations if we're going to move the field forward. What to me is a very exciting project that's ongoing now is that the Narayana Health Group is now moving close to the US, to the Cayman Islands, and have developed what they're calling the Narayana Cayman University Medical Center, which I understand will start at 400 beds and will likely go up to 2,000 beds in their ability to provide care, not only for an area in the Caribbean that badly needs it, but also potentially draw in the idea of a medical tourism market from the US, where you could actually pay for the travel costs, the care, the recovery, and the travel back, and it would still be significantly lower cost than what you could get in the US. So I think these are the types of external pressure points that are going to be necessary to move markets like the US to actually think about this idea of reverse innovation and frugal innovation. So if we know that this is a type of activity that can cut across boundaries, how can we try to formalize these in a better way, especially into the US context? And that's where I want to spend the last several minutes. And I want to tell you about one program and one organization that we've recently launched. In November of 2012, we were able to partner with USAID out of the State Department and launch a $10 million program that's called the Social Entrepreneurship Accelerator at Duke, where through the resources of an entire university and academic health system, as a partnership between IPIHD, the Duke Institute for Health Innovation, the Business School, the Global Health Institute, the Public Policy School, really bringing to bear the broadest expertise available, what we developed is our own Global Health Accelerator. So the model is that we start with some of the best global health innovators from the world. And specifically, we're focused on India and East Africa as the two regions that we've prioritized in this program. And as we build this, we also are developing the resources and providing access to capabilities, including peer support, corporate and other academic mentorship, and bringing into play the burgeoning field of impact investing, working with a group called Investor Circle to actually mobilize private capital to be able to connect with these innovators. And through this mechanism have developed this accelerator program to take organizations that have some proven operational capabilities and move them to scale. And to do this, we're engaging our faculty and students across the university so that the expertise is brought to bear, whether that's in healthcare delivery or public policy. We're also making sure that what we're doing here is actually generating generalizable knowledge that can help others to move health innovations, but also into other sectors like energy and the environment. And finally, we're assessing social impact. As we've moved this work forward, there's an awareness now that there's very little data or evidence about what works in helping to scale social innovations, and we hope to add to that field. Now, this is a great program that brings together the breadth of what a university can do to move the field forward. But at the same time, we've also spent many years thinking about how to institutionalize into our own local context the idea of health innovation. And we know that to institutionalize innovation, organizations have to have not just a process and a structure, but there's got to be a culture, there's got to be an ecosystem to move this innovation process forward. And for us, this is the aspect of developing an entire framework for innovation. So it has to be built, if we look at the larger circle, on the ecosystem. So we have to understand the role of innovation within the organization. We have to know where the opportunities are. And building off that context, this has to be grounded in a very focused strategy of what's important in terms of innovation for our organization. And it has to be responsive to the people within the organization. So what's the culture and what are the capabilities we have to bring to bear in this field? And within that context, we have to put a process in place that's able to identify and evaluate ideas, that are able to prioritize what's important in terms of innovation, and then execute, very importantly, be able to execute and evaluate to see what works and what doesn't work. And for Duke, the way we've put this innovation framework together is through the establishment of the Duke Institute for Health Innovation. We built programs over the last 5 to 7 years that now have culminated in the launch of the Institute this past September. And what we felt were the most high priority areas for us as we put our innovation framework together were these four. The first around implementation and health delivery science, so really taking evidence and putting it into practice to help scale innovations. So this will work with the Social Entrepreneurship Accelerator at Duke, as I mentioned, with IPIHD, to take all of our global lessons learned and pull it back into a local context for Duke as well as the US. So we're creating out of our own $3 billion health system a living laboratory where we can test ideas and principles that are coming out of our global work and put them into practice and scale them locally and into the US context. In addition, we're focused on health technology innovation in two ways. The first around leveraging big data and the analytics capabilities that are being brought to bear in order to move the field forward. And secondly, this idea of being part of the digital health ecosystem. As the number of applications, platforms, wearable devices expands rapidly, there's a role for academic health systems and universities to be able to build an evidence base and to help to scale. We've heard many times in the last day and a half about the need for workforce and leadership development, and we think that's a core role for a university to play. So everything from understanding the core aspects of leadership, quantitative health sciences, change management, to thinking about areas like clinical informatics, to putting into practice, into our clinical environment, things like high-value, cost-conscious care. We're trying to build an ecosystem where we provide the best training and professional development opportunities to train leaders for the future. And finally, we want to use all of the work that we're doing here and apply it into a health policy context, not in a theoretical way, but in a very applied manner that allows us to inform and advocate for the appropriate changes at the level of policy, regulations, reimbursement,